billions of people in record time, coverage of routine immunization protection for children from preventable diseases dipped and reached the worst level since 2009. According to the WHO, an estimated 23 million children under the age of 1 did not receive basic vaccinations in 2020. So how can we reverse this fall and increase routine immunization above the 85 to 86% level that was stagnating even before the pandemic? One approach focuses on reaching excluded children by engaging with communities. This edition of the 3IE Evidence Dialogues will focus on what we know about increasing routine immunization of children in low and middle income countries through community engagement. The session will include a brief presentation of findings from our new systematic review. Presentation will then be followed by a panel discussion touching on how policymakers and health sector specialists can translate these approaches into practice as they catalyze action to ensure all children get the shots that they need. For today's discussion, we're delighted to have Toby Ryman, Senior Program Officer at the Bill & Melinda Gates Foundation, and Lena Menning from the Department of Immunization, Vaccines, and Biologicals at the WHO in Geneva, along with 3IE's own lead evaluation specialist, Monica J. We'll be posting a link in the comments, which describes the event in further details and gives you the bios for our panelists. Before we kick off, just a few housekeeping notes. We invite you to send questions to the panel. Please use the Q&A box and not the chat function. And please name the panelists you would like a response from. If the event is disrupted for any reason, we will shut it down and reach out to you over email. The event is being live streamed on YouTube and shared on social media. If you're joining our event via live stream, please leave your questions in the comments box. Also, we encourage you to tweet any questions or points of view. Please tag @3IE News on Twitter and use the hashtag Evidence Dialogues. And without further ado, I'm going to hand it over to my colleague, Monica Jane, to walk us through the synthesis work. Monica, over to you.
Thanks, Sebastian. Are you able to hear me properly?
We do.
Okay, great. So I'm going to start the presentation. And so as Sebastian mentioned, we are going to be talking about our systematic review, where we are going to be launching it soon. It will be published as a Campbell systematic review soon, so it's forthcoming. Though I'm making the presentation, there is a very big team behind the systematic review, and here are the pictures of all the, all my co-authors. So the systematic review has 3 main objectives. One, we wanted to assess the effectiveness of community engagement interventions to improve routine immunization of children in low and middle income countries. We not only wanted to understand if the community engagement interventions are effective, but we also wanted to understand why and how they're effective. So we also aim to identify factors which are related to program design, implementation, and context, which are associated with intervention success or failure. Besides this, we also wanted to understand the cost effectiveness of this intervention. So that is the 3rd main objective of the systematic review. For our systematic review, first of all, we had to define what community is. So for us, we defined it as a group of people who are served by a particular primary health facility. It could be a Kebele in Ethiopia, a ward in Nigeria, a subcenter in India. And it also encompasses a very wide range of stakeholders like caregivers, frontline health service providers, and also influential community members such as religious or other traditional leaders. We also developed a community engagement framework. So we looked at the real world interventions that have been implemented across the low and middle income countries. And we ultimately settled on a community engagement typology, which focused on when and how the community is engaged. We found that there are 3 ways that the community can be engaged: in the design of the intervention, in the implementation of the intervention, and the engagement can be embedded in the intervention. So when the community is engaged in the design, community input or feedback on the intervention is actually sought before the implementation of the intervention. And this feedback can take forms like it could be stakeholder in the form of stakeholder consultation. It could be in the form of formative evaluation or a pilot or other outreach efforts. For example, the community members could be asked about what is what is the form of incentives that should be given? Should we give rice or should we give mobile recharges? Also, if we are providing text or voice reminders, how should one phrase the text, the text in that? Or what dialect or what language to use for these reminders? The second type is when the community members are actually participating in the implementation of the intervention. So they could participate as healthcare workers, as facilitators, as problem solvers. So we only included those interventions in this design, in this type, where the community members involved in the implementation had some opportunity to affect or influence its implementation. And the examples are, so community could be involved in actually selecting the beneficiaries of the intervention, or the community leader could be involved in outreach activities and tracing the defaulter children for immunization. The third type of engagement is where it's embedded within the intervention. That is, a serious attempt is made to gain community support. And typically, this type of engagement is carried out through the development of new community-based structures, such as village health committees or community health volunteers or women's group. It could also be, an example could be, there could be immunization camps. So there is a day where the children are given immunization, as well as the community is engaged in dialogue. So now I'll take you after this, describing the typology of community engagement interventions. I will just give you a brief overview of our systematic review approach. Our search strategy was very wide, and we searched several important databases for the impact evaluations which were carried out in low and middle income countries, and also evaluated routine child immunization outcomes. The results of this search also fed into an evidence gap map, and my colleague will provide the link to it for those interested in it. So starting with this very wide scope, we identified around 43,000 records. And after removing the duplicates, we were left with around 29,000 records on which we did abstract and title screening. After doing this screening, we were left with around 1,300 records or studies, which we reviewed on full text. And then we excluded the studies on various factors, like, if the study was carried out in a high income country, it was not an effectiveness study, or it was not a community engagement intervention. And after doing that, we were left with 61 studies, which have been included in the systematic review. So the evidence base for the systematic review across the different research questions was, so for meta-analysis, we used 56 primary studies, and we could not use evidence from 5 studies because they did not have sufficient quantitative data for us to calculate an effect size. So like they did not have the standard error or the sample size or the p-values. For the qualitative synthesis, we took the 61 primary studies, and also we looked at an associated 47 qualitative papers and also 69 project reports, which we identified through a very targeted search. For the cost effectiveness analysis, we have 14 primary studies, which had sufficient data, which was both on cost as well as effectiveness, which was needed to do the cost effectiveness analysis. So here is the distribution of included studies by type of community engagement. So you would see over here that engagement, which is embedded in the intervention, we had 27 studies in this type. Then in those which community was engaged in design, there were 16 studies. And then engagement in implementation with some autonomy, we had 5 studies. And then there were studies which had multiple engagement types, and these were 15 in number. Here is the distribution of included studies by geography. So we see a lot of evidence is concentrated in South Asia, and a lot of studies have been conducted in India. Then if we look at Africa, that's another big chunk of evidence, in Africa. And there are also a lot of studies that we had from Nigeria. And then we have a few spattering of studies from Latin America, which are 3 in number. So now I'm going to go on. Sorry, I'm just going to make sure that I didn't miss anything. Yeah, okay. So now I'm going to showing the meta-analysis results. And we use the random effects models to those who might be interested in that. The rows correspond over here to the primary outcomes of the systematic review, which was full immunization, measles, DPT3, timeliness of full immunization, and timeliness of DPT3. The columns correspond to the intervention types. That is, the first column just basically have all the different engagement types put together. And then the last 4 columns are by the engagement type. That is, engagement embedded in the intervention, engagement where community is engaged in the design, then community is engaged in implementation with some autonomy, and then we have the multiple engagement types. So also you would see stars, 1 star, 2 star, 3 stars. So if you see 1 star, that means that is the confidence, the results are significant at 5% confidence level. And then if 2 stars at 1% confidence level and 3 stars means 0.01% confidence level. So we see if we take all the community engagement interventions together, we find that it has positive plus statistically significant effect on all the primary outcomes that we had, put down in our protocols. So whether it is full immunization, measles, DPT3, or their timeliness, these interventions affect them positively. Though the effects are, in terms of magnitude, and these are standardized mean differences, the magnitude are generally thought that these are small magnitudes. When we look at the intervention type where engagement is embedded in the intervention, we again see the positive effects, and they're positive and statistically significant for all the coverage outcomes. For the timeliness part, we did not have sufficient data to do this analysis. When we look at engagement in the design, it again has positive and statistically significant effect on full immunization and measles, but for DPT3, it's positive but non-significant. And for the timeliness, it is again positive and statistically significant. For the engagement and implementation, we see that these are positive effects, but they're not statistically significant. And for multiple engagement types, we only find that it has a positive and statistically significant effect for DPT3. We also, now I'll discuss the factors which are, underlying this intervention success or failure. And these can be categorized into 3 main categories. So first is the contextual factors. And not surprising, we found that interventions that ignored contextual factors during design tended to fail. And also contextual factors could act as both barriers as well as enablers to an intervention. The common contextual barriers that we found in the literature, which came out consistently was like the caregiver reporting transport or opportunity cost to be a barrier. So opportunity cost would be, there's a loss of wages or a woman is inability to do her housework if she has to take her child for immunization. There were logistical barriers which were mentioned, such as wait times or language barriers. Distance to the health center was mentioned consistently, and then limited availability of service was also mentioned. While we had the barriers, we also had the contextual enablers. So if there was a positive caregiver perception of immunization, that was associated with intervention success. Also, if there was availability of good health services, again, it came out as an enabler to intervention success. The second thing that we looked at was, in terms of the factors, was the intervention features, what are associated with intervention success. So what was interesting was we found that community engagement features themselves were associated with intervention success. And these included if the intervention involved conducting stakeholder consultations, holding community dialogues, or involving community leaders, those were associated with intervention success. Not only community engagement features, but also non-engagement features, like if the incentives were given to caregivers, if there was leadership and supportive supervision to health workers, that was also associated with intervention success. Then we looked at the third factor. We looked at the implementation part. What were the challenges that the studies reported? And again, not surprising, if the intervention was not implemented as planned, which we call fidelity, low fidelity, then that was a very common reason for intervention failures, and it was across all the engagement types. Also, if the interventions did not properly account for realities on the ground, that came out to be a very important challenge. So if the intervention had a very important part of sending messages, and if there was limited cell phone service, and if that was not properly taken account into, it led to failure of the intervention. So, or if the intervention needed time of the health workers and they were not available, again, the same problem. There was also some context in which there was political instability, and that led to problems in implementation of interventions. And again, not properly accounting for these realities led to their failure. There were also administrative challenges which were mentioned, like the technical challenges, like a phone app crashing, or political challenges. They did not get support from primary government stakeholders, which led to delay in timeline, or staffing challenges, we have already talked about. Because of inadequate staffing, they could not keep track of, suppose, defaulted children. So now we are going to move on from the factors to the cost effectiveness analysis. And what we found was that the median intervention cost per treated child per vaccine dose to increase absolute immunization coverage by 1% was $3.68 US. And this is what, for those who are interested, incremental cost effectiveness ratio. We also had a range of cost effectiveness numbers. It went from $0.88 to around $30 across the studies that we had. To compare it, there is not that much evidence. There are not that many systematic reviews which do cost effectiveness analysis. We only found one, which would be comparable to our systematic review. And there, the estimates range from $0.69 to around $170. And the interventions were not, common. There was not like a common time variable to them. And they included demand generation intervention, cash transfer programs, health system strengthening, and novel technology. So our range of estimates are actually not as wide as what has been reported or found in the other systematic review, which also focuses on around immunization. So what are the implications for policy and practice? First is that we find that community engagement interventions are effective tools to improve immunization outcomes. We found some intervention types like engagement embedded has the strongest effects. And then we also found these reasons, which I've already discussed, like having appropriate intervention design, like building in community engagement features, addressing contextual barriers, or accounting for preconditions like regular internet service. They were all very important. And these are the things that one needs to keep in mind, when they are designing the interventions. We also could do the systematic cost comparison. So we showed that these are feasible. And so now the decision makers can choose intervention based on both impacts and costs for whom it was available. There are also implications for research, we did not have very clear description of intervention components. So it was very difficult to actually, for us to understand or identify what exactly these impact evaluations are evaluating. So in the future, it would be useful to have more description and better description of these interventions. Also, a lot of evaluations, most of them did not have subgroup analysis. So if you want to understand equity considerations, we could hardly do anything in this area. We also could not, most of the studies did not incorporate qualitative research. So we failed to understand the mechanisms that lead to success or failure of the intervention. So that is another area in the future of, the evaluators, if they could report on why they think their interventions work and not just if the interventions are working. And of course, I think the quality of cost data, that was a very big pain point for us. Most of the studies did not have that. And this is the last slide. So the major limitations for this SR were, we had good evidence base for some intervention and outcome combinations and not for others. Most community engagement interventions are in combination with other intervention components. So basically the unique contribution to changes in outcome is very difficult to establish. And then I've already talked about that we had limited availability of cost data that is only for 14 studies. So I'll stop over here. I'm really looking forward to the panel discussion and also comments and questions from the wider audience. Over to you, Sebastian.
Great, thank you. Thank you so much, Monica, for walking us through the systematic review. And yeah, inviting all of our participants to start adding in your questions, comments through the Q&A box. You can start sending us your comments now as we sort of enter into the panel discussion. So I'd actually like to kick off the discussion with a question for you, Monica. Could you provide us with the rationale for the community engagement framework used in the systematic review, which of course is different from the widely understood spectrum of community engagement?
Yeah, thanks, Sebastian. And I think it is a very important question because in the protocol, we had said that we use the spectrum of engagement, which is basically, provides increasing, the rationalization is that, it provides increasing empowerment to the community to both identify the needs of the community as well as, provide the decision-making on the issues that they get affected by. But when we actually tested this, spectrum of engagement framework on the interventions that we found in the real world settings, the way the interventions have been implemented are very different and the motivation is very different. So in these interventions, it was not really the community which was identifying the need, but typically it were the health professionals who were identifying the need. And the rationale for community engagement was that if we involve communities and adapt the interventions to the needs and preferences, that will lead to better acceptability as well as better or more appropriate interventions. And eventually that will improve effectiveness. So when we looked at that, we realized that, the spectrum of engagement would not work. The best thing that we could come up with was to concentrate on developing a typology which was concentrated on when and how the community was engaged. So the focus more on the process of engagement. And that's how we came up with this typology, which went away from what we had discussed we had put in our protocol.
Great, thanks, Monica. And now I'd like to ask a few questions to all the panelists. I'm going to kick it off with a question, maybe starting off with Lisa and then asking Tove to come in and complement. So I'd be interested to know what kind of barriers to vaccination uptake community engagement interventions could potentially address, especially thinking about the demand side barriers and those related to vaccine hesitancy. Lisa, I would love to hear your thoughts on that. Over to you.
Thank you so much, Sebastian, and it's really a pleasure to join this panel today. So I would say, in short, that community engagement interventions have the potential to act on any of the barriers to vaccine uptake. And so in recent years, with experts and partners, we have developed a framework, the behavioral and social drivers of vaccination framework, which defines 4 drivers of vaccine uptake. And in brief, these are thinking and feeling, and these are confidence and attitudes. Secondly, social processes. Thirdly, motivations and intentions. And lastly, the practical issues. And practical issues are particularly important because they unpack availability, accessibility, affordability, elements of the service experience. And for example, elements that include the cost of those out-of-pocket costs of getting a vaccination as well. So the important what's critical here about community engagement is that it can offer us vital insights from the community that enables us to better understand what are those real reasons for low uptake through partnering, listening, engaging, and working together then to overcome those various barriers. So I would say that no matter the barrier, it's really important to be working with communities to together understand what those barriers are. And then secondly, to be designing, implementing, and evaluating those interventions as well.
Thanks, Lisa. And Tove, we'd love to hear your thoughts on this.
Great, and thank you also for the opportunity to be a part of this panel. I really agree with Lisa. I think that this approach can address nearly any barrier, and frankly, it can address barriers that probably aren't even on our radar and that we aren't thinking about. I think in the immunization program for a long time, we have tried sort of one-size-fits-all approaches to implement, and that's done a great job. We've achieved 85% coverage, but to really reach those last kids, I think we acknowledge that the limitations and barriers for being able to vaccinate those kids are really context specific. They're localized in each of the communities. And so I think that for us to be able to understand what is needed to reach children in these distinct contexts, it's really important to reach out to them, and community engagement is a way to do that and a way to truly understand what are their barriers. And so not only do I think that it's opportunities for like any known barrier, I think it's probably also a way to surface additional barriers that are not even currently on our radar. I was going to say, I also think that there's strong evidence to suggest that engaging communities is a really important way to be able to address some of the trust and hesitancy issues that are at the core of demand. And so I think that it's sort of a two-pronged, both that helps you know what are the barriers, but also builds those relationships and the trust that can really help to strengthen demand for service delivery. Thank you.
Great, thanks, Tove. We're already getting some great questions from the audience, so thanks for sending those in. Keep them going. I think we have one actual follow-up question to this discussion, so I'll take it now. It's for Lisa, and the question from Teresa Norton is whether the behavior change framework that you've discussed addresses the impact of misinformation in vaccination uptake.
Yeah, that's a great question. So yes, it does. We do assess exposure to bad information. Essentially, we don't depict it as misinformation, but we do include that as part of the 20 or so constructs or themes that we do assess with the main survey tool. And I would also say that you know, in the last few years, we have seen a lot of attention on the contribution of misinformation to eroding confidence and trust in vaccination. And I would say that the evidence is yet to really, I think, determine for us the extent of the impact on motivations and actual vaccination behaviours. Again, this is going to be very context specific, and it's going to be closely tied to the source of that misinformation as well. But we definitely do look at that together with you know, all of the other drivers that we're measuring. And I would also say that it's through our qualitative tools that are also closely aligned with our survey tool and the framework that I just mentioned. When it's through the qualitative tools that we are actually able to gather a deeper understanding, again, of the impact of misinformation on attitudes, motivations, and actual vaccination uptake. And we know that also the process of the dialogue and the conversation, even through qualitative research, also in a way is an intervention in itself in engaging with and listening to communities. So that's another important approach to consider.
Great, thanks, Lisa, and thanks, Teresa, for sending in through that question. And if we could maybe find a link to the framework that we could share with the participants, that would be fantastic. So I'm going to move on to the next question, and Tove, I'm going to actually start off on this one with you, and then also ask for Lisa and Monica to chip in. And really the question is around the SR findings. In your view, which of the findings out of this SR of greatest interest, most useful for your work and for the community of practice in your view?
So I think one of the things that I find most interesting was, given the breadth of this review, the fact that we were able to see consistent findings across various geographies, various baseline coverage levels. I think that says a lot about the context in which community engagement interventions will work. And so for me, the fact that these findings were robust across such diverse contexts is really quite promising. I will also say that, you know, in some of the barriers and facilitators of this work, it's not surprising, but I think that it's a really important reminder of the importance of addressing community engagement as a sort of part of a holistic view of the system, and ensuring that, you know, the supply side aspects are in place. Like this can only work if the service delivery is there and available to be able to offer services at the same time. And so I think that that's also just maybe not surprising, but a really important reminder that came out of this review. And I'll say the other thing that I in some ways was surprised by was, given the sort of way in which community engagement was defined, it's in some ways almost surprising to me that we didn't find more studies in this space. Thinking about how important it is to engage communities in nothing else than the design of an intervention. And so the fact that there weren't even more studies that could be included was I guess a bit surprising to me. But like I said, overall, I think that the most important thing to see here is just how robust these findings are across various contexts.
Thanks, Tobin. I think that's a very important point, that still scope for broadening the evidence base in this area. Would love to hear from Lisa and Monica on the same question.
I mean, yeah, absolutely. That we have so many questions still unanswered here, particularly as we look closer at specific contexts and specific population groups. And I think that, you know, as Monica very well illustrated, some of the implementation challenges and preconditions for implementing community engagement interventions are really some of the factors that are hampering our ability to do this systematically. And I think we, as part of, you know, further research on the interventions, looking closely at those preconditions or precursors would also be absolutely critical. You know, I think at a global level, we have now so much knowledge and know-how, and increasingly there's focus on why we should be doing community engagement. And even, for example, in the Immunization Agenda 2030, which sets out our global strategy or plan for this entire decade, we have an important focus there on people-centered strategies. And that's absolutely unprecedented that we have such an emphasis on thinking about our beneficiaries of immunization as participants, as partners, and in thinking and putting communities at the heart of what we're doing. And so with all of that momentum, there is so much more activity now focused on engaging with communities, but in fact, less focus on these kinds of preconditions and what those preconditions are exactly and how we overcome them. And I think to be able to do this systematically everywhere that's needed, we do face gaps in coverage and equity. We also need to be paying attention to these elements like the technical challenges, the funding gaps, the staffing, the systems, the structural considerations. That really needs to come into play as well.
Thanks, Lisa. Monica, anything you'd like to add?
I think, say yes. I think great points. I think what Tove and Lisa have already mentioned. So I will just bring three other points. One, I think one important contribution of this SRS is just the topology of community engagement interventions. And I think because there is this dissonance, I feel what theory is about and what the practice is about. So I feel that is very important. I think that we found that we can't use spectrum of engagement because, if you look at guidance after guidance, it talks about that. But the way it has been implemented is totally different. The other part I feel is, I think Tove has already mentioned about uniformity. I think the robustness of results, I think is very useful. I think the third is it's reassuring, I think, to see at least some parts which we feel are under the control of the policymakers. So like some community engagement features were consistently came out that are useful. Like, if you engage, if you have stakeholder consultations, if you have community dialogue, if you involve community leaders, and these are the things that can be controllable. Like there are lots of things that we can't control, but there are some things that we can control. So I thought that was a very useful finding. The last part I think is very important is the cost effectiveness. Ultimately a policymaker wants to know how much does it cost. So while we could find it only for 14 studies, but we could do that systematic analysis for 14 studies. So I think that's very important because one of the few, as I said, it's only the second or the third SR which has been able to do it and to provide, a decision maker, both the impact estimates as well as the cost estimate. So I think that would be, I would say, highlight the, another major contribution of this SR. Over to you, Sebastian.
Thanks, Monica. And for the next question, I'm actually going to stick with you as the lead author on the study, and then come to Lisa and Tove for their thoughts. So, thinking about hard to reach populations, what do you think are the implications of the findings of the SR work for zero dose unvaccinated children and those harder to reach populations?
So this is something I think Tove and I have been discussing because it is so important now for Immunization Agenda 2030, the whole focus on zero dose children. So while in our protocol or in our analysis, because this zero dose concept was not there when we actually did the analysis, it has come out, it has come recently. So we did go back and looked at our findings. And so what we could do, because this definition of zero dose is like, how do you improve the vaccinated children who are not vaccinated, and the indicator is DPT1, like the ones who get DPT. So we had done the analysis of effectiveness of these interventions on DPT1, but the problem is the evidence base is very small. So what we find is the effects are positive, but they're not statistically significant. Now we know when we are in this area, we don't know whether they are actually not significant, like there is no impact, or is it because the evidence base is so small that, that hampers our ability to talk about, ability to infer more than what we are seeing. So I think for both DPT1 and BCG, BCG we had, in some models, we find some positive findings, which are also statistically significant. The findings are all over positive, but they're not statistically significant as far as the DPT1 and BCG doses are concerned. And those are the ones which we'll consider for the zero dose children. But as I said, the evidence base is very thin. On the other hand, when we look at DPT3, measles, we see very strong effects, which are consistently significant, statistically significant. And again, I think it is more to do, I can't say for sure, but then the evidence base is also very big on that, right? So we see statistically significant effects, and the evidence base is bigger. So right now, if we just go by without thinking about the size of the evidence base, it seems that the community engagement interventions are more effective for, the DPT3 or getting towards full immunization than for bringing the zero dose children, up, or bringing the zero dose children down. But again, the caveat is the evidence base is very thin. I don't think so we can make strong inferences, but that's what the evidence is right now indicating.
And Tove, would you like to add in any additional thoughts in terms of the implications for the zero dose and hard to reach populations?
Yeah, as Monica said, I think, the evidence is much more clear for those subsequent doses than it is for the early doses. And I think that could be, as Monica pointed out, the nature of how many studies there are and what they show. I think there's also potential that in some ways, the barriers for zero dose children differ than the barriers for children returning for subsequent doses. And I don't think that it's quite as straightforward as saying that zero doses is just an access problem, but we've historically thought of getting children into the immunization system as being something that we have to ensure that there's sufficient access. And so I think about some of those findings that if the service delivery isn't there, if supply isn't there, like community engagement can only get you so far. And so I think that this is a perfect example of where we need to ensure that the service delivery matches and is available as a part of how you also do the community engagement work, because you sort of need both pieces. That being said, I think that there is huge opportunity and benefit to think about how we can use this community engagement for reaching zero dose and hard to reach children. As I mentioned earlier, I think what it will take to reach the remaining children really varies a lot by context. We look in some countries, it's zero dose children are clustered in urban slums. In some cases, they're nomadic populations. In other countries, they're marginalized minority populations. The children who are zero dose vary substantially across contexts. And so I think that when we try and think about what are the approaches to reach those children, there's no one easy answer, even a handful of easy answers. Instead, I think that it really requires us to engage with those communities to understand what will it take to ensure that the immunization services are meeting their demands. And so even though I don't think that the evidence is super clear to show the exact linkage, I think that community engagement approaches should be core to how we're thinking about reaching zero dose and ensuring that whatever we're doing is contextualized and appropriate for the local context in which those zero dose children are living. So thank you.
Thanks a lot. And Lisa, anything to add here?
Only one small comment, which is that there are layers to community engagement, and in these kinds of contexts which are so unique, I think working through the various different kinds of community structures that might exist and different kinds of civil society organizations and community structures and community representatives. And I think that even though in some of these settings, it may be difficult to engage for all sorts of other reasons that may be political or otherwise, for example, in these, quite contested settings often that are fragile or conflict affected, that, we really do need to get creative in working through the different kinds of entities that exist at whatever level that enable us to ultimately start the conversation, to start gathering those insights about what are those needs for that specific context.
Great, thanks, Lisa. Let me stick with you, shifting gears a little bit. The next question on public-private partnerships. So the Immunization Agenda 2030 calls for broadening partnerships and for civil society, communities, and the private sector to work together towards common goals. So what do you see as the challenges to community engagement in the broader public-private partnership context? And how do we balance the interests of the community, especially those most marginalized, and private investors in public-private partnership projects? We'd love to hear your thoughts on that, and then go over to Tove for the same set of questions.
Yeah, I think that's a great question. And I would say that, at the end of the day, we're all working towards common objectives. And I think that where we are grappling with inequities in certain settings, there's a role for any kind of organization or entity to play a role. And I think that we, need to think about the different kinds of assets, if I can call it that different entities can bring to the table to resolve these challenges. So I'm very optimistic in thinking that, we can work together to find the right solutions, and to do that in a way that overcomes certain kinds of ethical considerations that really are important here. And I think I'm not a bioethicist, but I think that consulting with, people like ethicists, I think could really offer us a lot of important insights as to how to overcome certain interests that could lead us astray in various ways. So yeah, but I do think we need to look broadly across all sectors and all kinds of organizations for the contributions that they can bring to overcoming these kinds of challenges. And we do need a whole of society approach. And particularly now when we are thinking about life course vaccination and older populations and engaging youth and all sorts of disadvantaged and marginalized population groups, the more that we can be inclusive of different organizations across the society, I think the better.
And Tove, over to you for the same question.
Yeah, I don't have a lot to add. I really agree with what Lisa's saying. I think part of what IA 2030 aims to do is broaden the umbrella of partners and organizations that are supporting immunizations. And I think in general, that makes sense. We should be we should try and pull from the greatest expertise and greatest potential across various partners. And as Lisa mentioned earlier in another question, part of IA 2030 is that there's one of the principles, the core principle is around being people focused. And so I think that in some ways, to me, community engagement feels like a really concrete way to ensure that we're keeping to that core principle. And so I guess I would just say in terms of how we do this, I think ensuring that all of the partners are working towards the common IA 2030 goals with a particular focus around being people focused feels essential.
Great, thanks to both of you. Monica, I'm going to turn back to you now and ask what do you see as the challenges in strengthening the evidence base around gender and equity dimensions?
So great question, Sebastian. I have two main challenges, I feel. I think one is just the consciousness of importance of this research, which is equity-based and which is gender-based. And I must say, I think over time, we have seen quite a important, significant increase in this, recognition that it's important and one needs to do. What we saw in the evidence base was like there were very few or hardly any studies which did subgroup analysis by gender, by equity, by poor people, by women. Not only did they not do the quantitative analysis, we did not find that much, but also the qualitative analysis, right? How does these interventions impact gender or equity? That was, again, very, very sparse in the literature. So I feel that first is this consciousness that it's important, and we need to do something about it, which, as I said, there has been a remarkable, I think, change over time. The second, I feel, is the funding landscape. I mean, when we are talking about the subgroup analysis, especially when we are talking about evaluation studies, I mean, if we want estimates by gender, by certain equity groups, it means more treatment groups, it means more money. So I think there's just the realization that, it will take, I mean, in some cases, much more funding, especially when we are doing this evaluations is something that is important. So I feel that, so those two, I would say, the consciousness of importance and the funding landscape, realization, I think both, I feel are a challenge and an opportunity as we go forward and, want to build up this evidence base on equity and gender.
Thanks, Monica. And we're getting lots of really good questions coming in from the audience. Thanks for sending those. We'll be getting hopefully to a few more of those in the last few minutes that we have. But before we move to the audience questions, one final question, Tove, for you. What do you see as the highest priorities for investing in further evidence from the donor perspective?
Yeah, I think Monica highlighted a couple, and she actually just mentioned couple. I think that there is need for some improved measurement across the work that we're already doing in order to be able to better understand and learn from this work. I think secondly, there is importance in ensuring that we're designing studies in order to be able to look at subgroups to help answer questions around equity that are so essential right now, particularly as we're thinking about zero-dose children. But I think the final piece that struck me, and it's related a bit to the question that Liz Brown asked, is it feels like the evidence is strong and we know that it's robust across multiple contexts. So I think that there's really important questions around how do we begin to scale this? What does it look like to be able to scale community engagement approaches? How can that be done both within countries and across countries? And so that feels to me like a really important area for us to continue to fund and better understand.
Great, and that actually brings me, I think, to the first set of questions I was going to take from the audience, which is around, experimentation. If you had, your wish list of the sort of the top experiments or areas for furthering the evidence base in this area, we had questions from Liz Brown, Catherine Jones, sort of along the same lines. Would love to hear from the panel on this. So Catherine says, if you could design any experiment to look at how to make immunization a truly consumer-facing approach, what would you try? What would you try first? Not talking only about frameworks. And do you know of an example of a lower or middle-income country that has done this or done this well? And that, I think, is sort of related to the question that Liz sent through. So Liz asked, do you think that the literature is starting to hone in on which alternative community engagement approaches are most effective? And should donors focus on more experimentation in this space to learn about community engagement strategies, or should they do something else? So sort of an interrelated sort of questions there. Would love to hear the panel's thoughts. Maybe Lisa, I'll invite you in to kick us off, and then move on to Tove and Monica.
Yeah, this is a really great question. And I think it touches on so many different parts of the discussion so far about, I think there's a tension in that if we are to better experiment and better scale what works, we need some kind of standardization in this field. And as we heard from Monica in her presentation, what we've seen from the literature is that there's a lot of unclear definitions. There's not consistency in the components, the characteristics of community engagement. And I think ultimately to better advance our knowledge of what works and what works in specific settings for different populations and vaccines, et cetera, it would be really helpful to have some kind of harmonized, standardized approach to the different components of community engagement and also their measures. And I think that would really ultimately be a starting point to take us towards being able to answer these great questions that Liz has raised, for example. So I'll say that, but I'm sure that Tove and Monica have a lot more to add here.
Tove, over to you.
Sure. In some ways, it's similar to what I was saying a moment ago. Liz, I guess I don't think of it as much as an either or. I think there is more work that we need to do around improving how we are measuring and understanding current community engagement. But I also think that there is sufficient evidence that we can't just sort of continue to do pilots. We actually need to begin to see what it takes to be able to roll community engagement out more broadly and understand if that's something that can be scaled at a much larger level. And so I think we should be doing both of those things. I'll pass it over to Monica.
Your thoughts?
I'll talk only from the evaluation perspective over here. And that perspective is, I think, if you really want to know the contribution of community engagement interventions, I think that is one area I don't think so we were able to get to, because most of these community engagement interventions are in packages. Like there are other components to it. So I think I agree with Tove, I think ultimately we have to be pragmatic when we have strong evidence. I mean, it's not nothing, but I think how do we take it from here? And then how do we add where we want to reach is something I feel that would be important as we go along.
Excellent. And I see we are coming up to the top of the hour. And thanks to all of the participants for sending through your questions. Sorry we couldn't get to everything, but unfortunately, in the interest of time, we're going to have to start winding it down. I would like to just see if our panelists have any sort of concluding thoughts or remarks before we bring this to a close. I'll open it up for any final thoughts. Lisa?
I would just say that this has been such a thought-provoking discussion with excellent questions, and I really, the research, the systematic review that Monica presented, I think offers us such great insights and a starting point for future work in this space. So just really looking forward to picking up on that and helping to continue to advance this field, and ultimately also to do that together with communities and community representatives, and really have them closely engaged in all these research processes and research questions and the implementation considerations going forward. So, even on panels like this in future, having community representatives themselves so that they can also contribute and bring their voice to the table as well. So that's it for me. Thank you very much.
Thanks, Lisa. Tove, over to you.
Yeah, I just want to start by thanking 3IE for doing this. This was a huge undertaking, and I know has been a part of a multi-year process of digging into community engagement work. And so I just want to acknowledge and appreciate your pulling this evidence together in a way that allows the community to digest it and use it to drive how we do our work. The other thing that I would say is I agree. I think this is really important. And I think, I think a lot about those kind of spectrum or the various types of community engagement. And I can't help but believe that at a minimum, we should be ensuring that we engage in the design of our work in everything that we do. When we talk about being people-centered and we talk about designing for the users and ensuring that we're reaching people, like, engagement and design should be a minimum of how we work. And so I just really appreciate your bringing this forward. And I think that there's great opportunity for us to continue to push this and expand where we do this work. So thank you.
Monica, over to you for final thoughts in 30 seconds or less.
Yeah, I want to thank, I think, to all the panelists. I think it has been a really great discussion. I would also want to thank Tove, and Gates Foundation. I think they have been great supporters of this work. It was complex. It was time consuming, but they supported us through. Lisa, I've had several discussions. I think, we have also presented this work separately. So we've got some great comments. So I think it's been great support of these very important organizations, in this work. And also, I think just thinking about how we go forward. I would really, I think one thing that I really felt about this work was the standardization part. I think if we really want to understand community engagement, this is the inconsistency of these definitions across the literature and how people even think about it. I think if we can come to some kind of standardization as we go along, and at least just the understanding of community engagement, I feel that will be great. And of course, as our systematic review gets, launched soon, as a Canvas systematic review, I think I'm really looking forward to engaging more on this, just the typology of community engagement, that's just the frameworks, and of course, also the findings and what it means, for policy as well as research as we go forward.
Well, thanks again to the panelists, Tove, Lisa, Monica, for a very rich discussion. I'd also like to thank the whole team at 3IE that made the event possible, and to all of you for joining us in this engaging panel discussion. The live stream of the video will be uploaded on 3IE's YouTube channel in case you'd like to rewatch or share the webinar. And if you'd like to continue the discussion on Twitter, please hashtag 3IE News in your tweets. You can also subscribe to email updates from 3IE by visiting our website, 3ieimpact.org. to learn about future events in the Evidence Dialogue series. Thanks, everyone, and we'll see